Hello, good afternoon. Today we're going to see influenza or the flu. We have to consider that influenza is a seasonal respiratory virus infecting approximately 1 billion people. So let's write here 1 billion people. Yeah, globally each year. Um, each year. And it's important to recognize that it results in over 500 deaths annually. So, while most cases are mild and safe limit, influenza can result in complications such as we have pneumonia, hospitalization, and death. Particularly among vulnerable populations such as the elderly, young children, and those with underlying health conditions. So let's start talking about a life cycle. So first of all, we have to consider that influenza virus is an orthomyxoricus. So we have orthomyxoricus, orthomyxoricus that has a segment. So we have segment. It has segmented negative sense and a single strain RNA. Okay, so those are important things. This is orthomyxoricus has is segmented and negative sense and single strain RNA. Remember, S for single and the other S or strain. So it's enveloped within a host derived plasma membrane. We hold this like lipid bilayer, and it initially infects epithelial cells in the upper respiratory tract. Infection is a multi-step process. So let's start talking about two proteins that are important in this life cycle. Let's start talking about viral hemagglutinin. So we have viral hemagglutinin. Hemagglutinin. This is also called like H1. So, H. This binds to salicylic acid, the receptors on the host of the cell surface, and followed by entry by endocytosis. Yeah. So let's draw here this cell. Okay. So we have the salicylic acid here, and then the virus has in this capsule we have this malglutinin. So let's say that this is in the malglutinin or H. Then we have here the neuraminidase, but yeah, we are going to talk about the neuraminidase later. So here the malglutinin binds to the receptors in here in the salicylic acid. It's important to recognize this salicylic acid because later we are going to talk about the drugs that this management that specifically those drugs that work like agonists or of these salicylic acids. Yeah. So it's important to consider this viral hemagglutinin that binds to salicylic acid receptors on the whole cell surface and follow by entry by via endocytosis. Okay, so then we have this acidification within the endosome. So hemagglutinin undergoes a conformational change, encoding the virus and realizing the viral RNA into the cytoplasm. Yeah. So as I was, so this is completely important because we have hemagglutinin, hemagglutinin, hemagglutinin. It's in. Okay, so in is let the virus in. Let the virus in. Okay, let the virus in. Hemagglutinin, let the virus in. And then we have the other protein that it's neuraminidase that send the virus away. So neuraminidase, yeah, that send the virus away. Send the virus away. So here we have neuraminidase send the virus away, and the hemagglutinin let the virus in. Okay, so um, then we have this acidification in the endosome. It's important to recognize this acidification and the proteins that are in the surface. So upon acidification within the endosome, the hemagglutinin undergoes a conformational change, uncovering the virus and releasing a viral RNA into the cytoplasm, like I was telling you before. So the RNA is transported to the nucleus, yeah, and where it's transcribed into RNA messenger by viral RNA dependent RNA polymerase. So here we have that the RNA is referred to the nucleus. So here we have the RNA that it's entered into the nucleus. Um, Before that, we have to consider that in this endosome we have an entry of hydrogen ions. So we have hydrogen ions. Yeah. Then we have another important thing that it's the M2 channel. Yeah, the M2 channel. Then we have this encoding. So let's draw here. We have the cell, we have the hemagglutinin, and then the endosome. They start the acidification, M2 chapter. So we have M2 chapter. Here is the RNA. Remember that it's an RNA single strain negative sense. Yeah. Then start here. This is the M2 channel. Then we have the encoding. Yeah, encoding. And then this enters into the nucleus. Okay. So the RNA is transported to the nucleus and where it's transcribed into messenger RNA. Yeah. This is thanks to the viral RNA-dependent RNA polymerase that we could write here like DRP. Remember, RNA-dependent RNA polymerase. Yeah. So RDRP is a unique polymerase that snatches host 5-cap. So remember that we have the pre-RNA messenger. So let's write here pre-RNA messenger. These, and then we have this mRNA and process. Okay, mRNA process. So here, this RNA messenger. Remember that we have 5, and here we have a 3. So in this case, we need 5-cap. Yeah, 5-cap. This 5-cap is important because that will helps you to avoid the destruction of enzymes that are in the cytoplasm. Yeah, and then we have here the poly-A tail. This poly-A tail. So 5-cap, it's important. So the RDRP, like I was telling you, is a unique polymerase that snatches host 5-cap, yeah, to establish the RNA and facilitates support back into the cytoplasm for translation. Yeah. Then we have this viral RNA is translated into the viral proteins. So then we have this translation into the viral proteins thanks to the ribosome. So we have here the viral proteins. These include the involved proteins like hemagglutinin, neuraminidase. Also, we have that neuraminidase. Like I was saying, you neuraminidase ways. This is to send the virus away. So what's the function of neuraminidase? Neuraminidase? Well, neuraminidase clips sialic acid and residues on the host surface, allowing the virus to detach and spread to neighboring cells. That's the reason that some drugs will work here. It's like a agonist of this sialic acid, so they could these neuraminidase won't destroy this salicylic acid. So this virus will attach in the super in the in this capsule, and they not the virus, um, we have here the effect that the neuraminidase ways not will send the virus away. Yeah. So most mutations are insignificant, but some confer a greater virulence, or allow the virus to live across host species. Yeah. Uh, for example, hemagglutinin mutations in influenza, we have the HN1. Yeah. Allow it to bind strongly to human cells in addition to avian cells. Another important thing that we have to consider is this that I'm talking about this strain diversity. So strain diversity. We have two examples: antigenic antigenic drift, and the other that is shift. Remember that drift. When we talk about drift, we have to think always in random mutations. Okay, so we have here random mutations, and this is due to a poor proofreading of viral RNA-dependent RNA polymers and cause progressive change in viral proteins. And most mutations are insignificant, but some confer a greater virulence or allow the virus to live across host species. So, like I was telling you, this mutation of H1N1, the influenza, that allows to bind strongly, yeah, to human cells, and this is the antigen drift. Then we have the antigen shift. So antigen shift, occasionally two viral strains. Let's write here the virus A and virus B. So we have two types of this of virus of influenza. So here's the cell. Start the co-infection, virus A and B, and then we have like a resortment. As a result, we have this mutation thanks to two types of virus, and this enables, yeah, the viral genomes to undergo this resortment. Uh, and this is important for segment viruses such as influenza that have multiple RNA strands, each encoding a different protein. Yeah, so producing new viral combinations. Resortment is more likely to occur in crowded environments where different strains from multiple host species can meet. For example, pig and chicken, yeah, wet markets. So it's important to talk about antigen drift and antigen shift because antigen drift and antigen shift give these mutations, and that's the reason that we have uh, to have this vaccination, yeah, every year, and these seasonal stages, we have to back we have to receive this vaccination. Yeah, it's important because mutations occur thanks to different types of virus or random mutations in the same virus. So, well, influenza strains from around the world are constantly being sequenced by a global surveillance system. Uh, the system that sequence the influenza strains, it's called Centers of Disease Control and Prevention, or the CDC, the Centers for Disease Control and Prevention, and the World Health Organization. So this allowed the composition for the following year's seasonal vaccine to be adjusted. Remember, seasonal vaccine, it's important. So we have different types of seasonal pandemic influenza. Remember that seasonal pandemic influenza is a respiratory illness that peaks in the fall and or winter. Flu season, typically between October and February in the United States, and most causes are caused by three strains. So we have influenza A, H3N2, we have A, H1N1, and we have the influenza B. Okay, so influenza A, H3N2, It represents 60% of cases. Yeah. H3N2 influenza has a broad host ranges in human, birds, and it's important because it's the dominant flu strain in America, causes of severe disease in patients who are elderly, more than 65 years old, and those with chronic medical conditions. You have the influenza A H1N1. This is 3% of cases. So H1N1 influenza has the same broad host range as stage 3 and 2. Yeah. It causes more severe disease in younger, previously healthy adults, potentially due to its ability to elicit a powerful inflammatory response. And finally, we have this influenza B with 10% of cases. Remember that influenza B comprises two lineages. We have Victoria and Yamagata. Okay, Victoria and Yamagata. We have to remember these types of influenza B, Victoria and Yamagata. In contrast to influenza A, it infects only humans, not swine or birds, and evolves more slowly, primarily through this that we call the antigen drift. Remember that random mutations are that occur. So influenza B generally causes this milder illness than influenza but can still cause significant complications in young children. So the trivalent seasonal influenza vaccine, we have this trivalent. Trivalent contains H3 and 2, H1, H1N1, and the Victoria. Okay. And the quadrivalent vaccine, that's the Yamagata. But here we have the quadrivalent. Okay. Okay. So, what's a clinical presentation? Let's talk about the clinical presentation of influenza. Clinical presentation. So influenza has a wide range of severity, ranging from a milder self-limit illness to severe complications affecting multiple organs. We have uncomplicated influenza. So uncomplicated influenza refers to a self-limit. Yeah, so self-limit illness primarily affecting the upper respiratory tract without leading to organ dysfunction or requiring hospitalization. So it's the most common presentation of influenza in otherwise healthy individuals. After an incubation period of 1 to 3 days, influenza usually presents with system symptoms. Remember that systemic symptoms are more pronounced than the upper respiratory symptoms. So we have these systemic symptoms. This are about onset of high fever, often more than 38.5 rates, or if we call here the 101.3 rates of Fahrenheit. Also, we have chills, generalized myalgias. Okay, generalized myalgias, especially lower back. Okay. So then we have the headache, severe fatigue or malaise. And the upper respiratory symptoms, remember that systemic symptoms are more pronounced than the upper respiratory symptoms. Nonetheless, we have these upper respiratory symptoms like pharyngitis. So we have pharyngitis, that is a sore throat, okay? Cough, nasal congestion with burning and sneezing. So nasal congestion. So with influenza, systemic symptoms are more pronounced, like I said, than the upper respiratory symptoms. With other respiratory viruses, in contrast, the upper respiratory symptoms predominate. So this is important to establish the diagnosis. So patients often describe influenza as the worst cold I've ever had. So imagine here the patient, oh doctor, the worst cold I've ever had, and I present this headache, yeah, the cough, nasal congestion. Remember that the systemic symptoms are more pronounced, so it starts with the fever, chills, general myalgia, headache, severe fatigue, and malaise. So elderly or immunocompromised patients, these immunocompromised patients may present with atypical symptoms. For example, a febrile illness. They don't present this fever, uh, weakness, psych, and altered mental status. Okay, so symptoms typically peak at 1 to 3 days and resolve over the following 4 to 7 days. And persistent fatigue and nagging post-infection cough are common, often lasting for multiple weeks. And it's important to recognize that laboratory tests are typically normal or may show only subtle abnormalities. So let's write here that the laboratory test we have normal or may show, like I said, subtle abnormalities like slight leukopenia or thrombocytopenia. So we have here this thrombocytopenia. So to this thrombocytopenia, that chest imaging is typically clear. Okay, so it's completely normal. This is a uncomplicated influenza. Let's talk about complicated influenza. So complicated influenza refers to a severe presentation with organ dysfunction or severe symptoms requiring a hospitalization, and these complications are more common in high risk populations. So um, let's draw here a table. These tables help me to remember the conditions associated with higher risk of influenza complications. So first of all, we have age, less than 2 years or more than 65. Also, we have chronic pulmonary, renal, cardiovascular, neurocognitive disease, nursing home residents. This is the third point, nursing home residents, diabetes mellitus, immunosuppression. They include HIV. In another video, we are going to talk about HIV. The management, it's important, and it's incredible how these drugs work. Um, so we have this immunosuppression, pregnancy, age less than 19, or long-term aspirin therapy, and the morbid obesity. Also, we have this American Indian or Native American. So, yeah, it's important to recognize these um, conditions associated with higher risk of influenza complications, such as the elderly, this diabetes mellitus, HIV, nursing home, chronic pulmonary renal, less than 2 years old or more than 5 years old, pregnancy, yeah, um, long-term aspirin um, therapy or use. So, the complicated influenza, we have pulmonary complications, and those pulmonary complications include primary viral pneumonia or secondary bacterial pneumonia. Okay, so primary pneumonia viral, but we could have the pneumonia bacterial or secondary bacterial. And bacterial pneumonia is the leading cause of death from influenza, and it occurs because the respiratory epithelium is denuded and cells are paralyzed by influenza infection. And this allows the bacteria, for example, Streptococcus pneumoniae or Staphylococcus aureus, to gain a foothold And this is important because patients typically have initial improvement in symptoms followed by sudden dramatic worsening, fever, purple, and sputum. Also, we have the ARDS. So ARDS, bilateral fluid infiltrates and severe hypoxemia. So ARDS, due to viral or bacterial pneumonia. And then we have the cardiac complications. So in this case, we have the pulmonary complications, and now let's talk about cardiac complications. It's important to recognize that in cardiac complications we have this pericarditis, so perhaps pericarditis and myocarditis, and the acute or coronary syndrome with a tenfold elevated risk during the first week of influenza infection. It's important to recognize the acute coronary syndrome. Also, we could have musculoskeletal complications, including myositosis, rhabdomyolysis. Yeah. And it presents with severe muscle pain and tenderness, particularly in the lower extremities. Yeah, so weakness is usually present, producing a myopathic gait or inability to walk altogether. So laboratory testing shows markedly elevated creatine thinness and potential muglobinuria to acute kidney injury of rhabdomyolysis present. So, and finally, we have the neurologic complications are rare, but can affect the cerebrum, encephalitis, cerebral seizure in children, spinal cord, peripheral nerves, for example, Guillain-Barré syndrome. So, yeah, in addition to these complications, influenza frequently triggers acute exacerbation of underlying chronic conditions such as heart failure or COPD. Yeah, these chronic obstructive pulmonary disease and asthma. Yeah, so it exacerbates these triggers acute exacerbation of these underlying conditions. To make this, the diagnosis is a presumptive clinical diagnosis of influenza can be made in patients with typical symptoms, like we say fever, myalgias, headache, generally myalgias, headache, chills, more than 38.5 rates. We could make the diagnosis, or this presumptive clinical diagnosis, but the definitive diagnosis is confirmed by a polymerase chain reaction. So for diagnosis, we have um, this the PCR, yeah, the PCR, that is the polymerase chain reaction or influenza A B test antigen testing. So PCR I is preferred because that has a high sensitivity and specificity and is usually performed as part of the multiplex respiratory virals. And this can detect several viruses, for example, respiratory syncytial virus, yeah, adenovirus. Okay, so definitive testing is unnecessary for most previously healthy adults, and nonetheless, it's indicated for patients that who are at a higher risk of influenza complications and may benefit from antiviral therapy. So we have to consider the antiviral therapy, for example, oseltamivir, tenofovir, baloxavir. It's indicated if influenza infection is known or suspected. We have to consider three points. We have any hospitalized patient will receive this therapy of this antiviral therapy, or any outpatient presenting less than 48 hours after sign of onset. After that, we have the any outpatient of higher risk of complications regardless of sign of onset. Let's we talk about this that it is these conditions that triggers to that triggers a higher risk of influenza complications. Yeah, so the third point will be these conditions associated with higher risk of influenza complications, and treatment reduces these risk complications, shortens the duration of symptoms by roughly 1 to 2 days. Yeah, of course, if it started within 8 hours of illness onset, and decreases the risk of transmission. So yeah, it's important to consider these points to start an antiviral therapy. Uh, so right now we're going to talk about the management. Management is important because we have several classes of anti-influenza antiviral drugs. Let's start with the adamantines. Adamantines, such as amantadine, and rimantadine. So we have here amantadine or rimantadine, amantadine, rimantadine. Yeah. Um, well, those amantadine and rimantadine inhibits the viral replication. Um, it's important to recognize that they block the M2 channel. The M2 channel. Remember that the M2 channel, we study here that in the endosome or this acidification, we need the M2 channel. But what's the function of this M2 channel? What's for this M2 channel? Well, this M2 protein channel it's necessary for influenza occurring in the acidic lysosome. However, widespread resistance among most seasonal strains of influenza A have rendered these drugs largely obsolete. I'm talking about this amantadine and rimantadine. But yeah, we have to consider this, the mechanism, this block that blocks the M2 channel. Yeah. So, amantadine and rimantadine, so they inhibit this viral replication. Yeah. And in sometimes, and sometimes that has an delay effect. Yeah. So